Hello and welcome back to GP Video Podcast by Nadia. Today is Christmas, so wishing a very happy Christmas to all my viewers. Okay, so yesterday we started the topic of heavy menstrual bleeding or menorrhagia, and today we will be continuing with that topic only. So I said yesterday that heavy menstrual bleeding is also known as menorrhagia, and 1 in every 5 Australian women suffer from this. It is also defined as excessive menstrual blood loss, which interferes with women's physical, emotional, social, and material quality of life. So this is something which could be very distressing every month for a woman who suffers from this condition. So we need to know what are the conditions, what is physiological, what is pathological, like what are the causes of, because usual menstrual blood loss should be 40 ml and the bleeding days should not be more than 7 days. But if it is more than 40 ml, especially more than 80 ml and more than 7 days, passing large clots and have to be changing pads every 1 to 2 hours, is actually really very distressing. And not only it is very distressing, but it can land a woman into many other issues like iron deficiency and anemia. So we have to look into what are the causes which can be treated and what are the causes which nothing much can be done, but it can't be cured, but it can be treated according to the symptoms, like the hormonal pills can be started, or what are the other strategies that can be done. So when we talk about heavy menstrual bleeding or menorrhagia, we can actually classify the causes into few categories. Number 1 cause of heavy menstrual bleeding is dysfunctional uterine bleeding, which actually accounts for 40 to 60% of all menorrhagia or heavy menstrual bleeding cases. I would again go towards what are the diagnostic criteria of heavy menstrual bleeding, because we can easily say, okay, 40 ml is the usual, 40 milliliters is the usual blood loss, anything more than 80 ml is menorrhagia. But how will we quantify it, and how will we, because this is just easy to say, but how are we gonna quantify it, because women can sometimes over or underestimate their bleeding. So the diagnosis is based on symptoms such as changing pads every 1 to 2 hours, bleeding lasting more than 7 days, any bleeding lasting more than 7 days, and passing large clots. So any one of these or 2 of these or all 3 of these are usually termed as heavy menstrual bleeding. A diagnosis can be made based on a self-report of very heavy periods, and as I said, that heavy menstrual periods can have a significant impact on quality of life. Dysfunctional uterine bleeding is the major cause of heavy menstrual bleeding and impacts on women's health both medically and socially. It is the diagnosis in 40 to 60% of women with excessive menstrual bleeding, which is defined as greater than 80 ml. The assessment of, as I said, heavy menstrual bleeding is quite subjective, and women may over or underestimate their menstrual loss. And as I said, the symptoms and signs that may signify heavy menstrual bleeding include an unusual increase in blood loss, more than 7 days of bleeding or flooding not contained within pads or tampons, clots greater than 3 centimeters, and the presence of signs of anemia or iron deficiency on blood testing. Dysfunctional uterine bleeding, as I said, is a common problem in women in the 30 to 50 years age group. The pathophysiology is not fully understood and it is complex. It is a diagnosis of exclusion though. So we will only come to the diagnosis of dysfunctional uterine bleeding when we have excluded all the other causes by history taking, physical examination, blood tests, and scans. Uterine and systemic causes should be excluded before the diagnosis is made. Dysfunctional uterine bleeding can also be more prevalent, as I said, between 30 to 50 years of age group, but they're also more prevalent at the both extremes of age. One, at menarche, when a girl starts menstruating for a few years, it could be really very heavy and stuff, or perimenopause, as we have already discussed in the section of perimenopause, that in perimenopause, the periods can either become light or become very heavy. So in those 2 extremes of age, dysfunctional uterine bleeding could be there. Again, even in those ages, if that happens, this is again the diagnosis of exclusion. We need to do blood tests, we need to do scans, and after we have everything has come back normal, then we can say that yes, it is dysfunctional uterine bleeding. We will talk about the management later, but let's now, after this functional uterine bleeding, which constitutes about 40 to 60% of the diagnosis in heavy menstrual bleeding, what are the other causes? What are the other conditions that can cause heavy menstrual bleeding? So they can be actually categorized into 4 categories: hormonal, changes within the uterus and cervix, blood disorders or medications causing blood disorders, and other systemic disorders. So if we talk about hormonal disorders, hormone-related problems often associated with very irregular periods can affect the lining of the uterus, resulting in heavy bleeding. Sometimes they can cause oligomenorrhea, like, they can cause very light or irregular bleeding, or they can cause menorrhagia, which is very heavy bleeding. Same one condition can cause both. For example, polycystic ovarian syndrome. It can result in both oligomenorrhea, which is very light, maybe lasting for 1 or 2 days and just staining, and it can also cause menorrhagia. Then we have got perimenopause. Again, in perimenopause, apart from dysfunctional uterine bleeding, we can attribute it to hormonal changes, and then the menses could be very light or very heavy. Then thyroid. Thyroid again, because thyroid gland produces hormones, which is FT3 and FT4, under an active thyroid. So hyperthyroidism, usually they say that hypothyroidism, which is underactive thyroid, causes oligomenorrhea, which is decreased menstruation, and hyperactive thyroid causes menorrhagia, which is excessive bleeding, but it could be the other way around. So any problems with thyroid, any problems with polycystic ovarian syndrome, or any other hormonal condition can cause menorrhagia. Then when we come to the uterus, there are a few conditions that can be actually excluded with a pelvic or internal ultrasound scan. There are fibroids, adenomyosis, uterine polyps, leiomyomas, precancerous or cancerous changes, and cervical cancer. These are the conditions that need to be excluded for the causes of menorrhagia. And then in other systemic disorders, some liver and kidney issues can cause menorrhagia. We'll come back to the treatment tomorrow.